CAD Risk-Factor Modification. All patients should be instructed about risk factor modification and medical therapies for secondary atherosclerosis prevention before leaving the hospital. The interventional cardiologist should emphasize these measures directly to the patient and family. Failure to do so suggests that secondary prevention therapies are not important. The interventional cardiologist should contact the primary care physician regarding secondary prevention therapies initiated and those to be maintained, including aspirin therapy, hypertensive control, diabetic management, aggressive control of serum lipids to a target low-density lipoprotein goal of less than 100 mg per deciliter following AHA guidelines, abstinence from tobacco use, weight control, regular exercise, and ACE inhibitor therapy, as recommended in the AHA-ACC Consensus Statement on Secondary Prevention. Follow-up schedule and stress testing. Access site is checked on the first office visit, 2 to 4 weeks following PCI. Stress testing is neither routinely nor annually performed after PCI, unless symptoms appear. If symptoms or signs of ischemia are present early after PCI, coronary angiography is repeated. There is no indication for annual exercise testing in asymptomatic patients. AHA and ACC practice guidelines recommend selective evaluation in patients considered to be at particularly high risk, e.g., patients with decreased LV function, multivessel coronary artery disease, proximal left anterior descending disease, previous sudden death, diabetes mellitus, hazardous occupations, and suboptimal PCI results. For many reasons, stress imaging is preferred to evaluate symptomatic patients after PCI. If the patient's exertional capacity is significantly limited, coronary angiography may be more expeditious to evaluate symptoms of typical angina. Exercise testing after discharge is helpful for activity counseling and/or exercise training as part of cardiac rehabilitation. Neither exercise testing nor radionuclide imaging is indicated for the routine, periodic monitoring of asymptomatic patients after PCI without specific indications. Medical therapy after PCI. Anticoagulant drugs, heparin, enoxaparin, are needed only for the brief intraprocedural period, unless indicated by unusual circumstances, e.g., continued intracoronary thrombus formation. Only bolus heparin without later IV infusions is used. In some labs, low molecular weight heparin, enoxaparin, is replacing bolus unfractionated heparin for PCI. Warfarin is not used for PCI but may be needed for other reasons, such as atrial fibrillation or severe LV dysfunction. Orally administered anticoagulants. Warfarin after PCI are no more effective than aspirin for preventing restenosis or abrupt closure. Antiplatelet agents. Platelet deposition is partially inhibited by selected antiplatelet regimens, aspirin and clopidogrel, ticlopidine, or prasugrel. Acute reocclusion is more frequent in patients who have not received aspirin before angioplasty. Late stent thrombosis is also more frequent in patients not receiving clopidogrel. Antiplatelet agents of the thienopyridine family. Clopidogrel, ticlopidine, prasugrel inhibit platelets by blocking adenosine diphosphate (ADP) stimulated aggregation and are highly effective for preventing subacute thrombotic occlusion after stenting. A rare associated side effect of ticlopidine, and lesser of clopidogrel, is thrombotic thrombocytopenic purpura. Clopidogrel is the currently preferred oral antiplatelet drug. Recommended antiplatelet regimens include aspirin 80 to 365 mg per day and clopidogrel 75 mg orally daily. Prasugrel is a third-generation oral thienopyridine which irreversibly antagonizes the platelet A5-diphosphate P2Y12 receptor. It can replace Plavix in patients who are non-responders or who have demonstrated stent thrombosis on therapy. It is not recommended for patients who weigh less than 60 kg, who have had a cerebrovascular accident, or who have any propensity for bleeding. Loading dose is 60 mg per oral and daily dose is 10 mg orally. Given in the intensive care unit or catheterization laboratory only. The intravenous glycoprotein receptor blocking platelet drugs, abciximab, tirofiban, and eptifibatide, block the final common pathway of platelet activation of the platelet receptor, called glycoprotein 2b/3, and are highly effective in blocking platelet adhesion to vessel wall and aggregation or clumping together. Reduced acute and subacute adverse event rates are reported for all three drugs. All high-risk interventions should consider using abciximab with heparin.